bird. It is good for you to see goodness in me. Thank you, Sushil. Dr. H.S. Chhabra is one of the most reputed spinal surgeons in India. His areas of expertise in spine surgery are robotic, computer-navigated and forearm assisted spine surgery under neuromonitoring. Minimally invasive surgeries including microscopic and endoscopic spine surgeries. Motion preserving spine surgeries. For any of the following indications like deformities, scoliosis and kyphosis correction, cervical spine surgeries, anterior and posterior, occipital cervical surgeries, spinal fusion, spine trauma, surgeries for spinal tuberculosis and thoracic myelopathy, congenital anomalies of the spine and spinal tumors. He heads various professional organizations like Spine Society of Delhi Chapter, Spinal Cord Society, Spine Wellness and Care Foundation, Spine 20, Spine Trauma Study Group of International Spinal Cord Surgery, and is a member of many other organizations. He is a highly acclaimed and accomplished surgeon. He has, to his credit, more than 25 prestigious awards for his research and outstanding contributions. So over to Dr. Chhabra.
Thank you, Dr. Bhargava, for your kind introduction. And I would want to start by saying that I am honored by the opportunity to be interacting with all of you. When I came to Delhi, that was 79. After the schooling, I joined University College of Medical Sciences, South Indian Hospital, and left South Indian Hospital in 91 and was associated with Indian Spinal Injury Center. So I've been pretty much in South Delhi, part and parcel of all of you. It's been only recently that I shifted to West Delhi, and Dr. Mangla has been a colleague, a dear colleague, and amongst the founder members at Indian Spinal Injury Center. So I've been interacting with many of you, some of my batchmates and college mates here, so it's very nostalgic for me to be speaking to all of you. One small addition I want to make. In my practice, in spine, you deal with back pain, and I have a passion for spinal injuries. So in spinal injuries, you could call me more a spinal injury clinician, because we spend more time in the rehabilitation of the patients than in the surgical management. And my effort today would be to talk about how any of us can be dealing with 97% of the spine ailments. It's only the remaining 2 to 3% who may need surgical intervention, who need to go to a surgeon. But any clinician can be dealing with spinal ailments which are second only to common cold in incidence. And 8 out of 10 of us would have a significant episode of back pain. 70% of them will have a recurrence within 1 year. In fact, back pain is responsible for the highest number of man-hours lost in the industry in US. That's why it's a very hot topic of research. Another, WHO recognizes it as the most common cause of disability across the globe, in most countries across the globe. So we are talking about some very common problems. We are also talking about a problem which is the most common reason to visit a doctor or hospital's emergency as per literature. So they can also have devastating consequences, right? You just need to see a patient with spinal injury to understand how devastating the consequences could be. And we talked about 800,000 disability adjusted life years globally every year. 1 to 2% of gross national product in Western nations. In fact, some estimates up to 3.5% of the GDP. So another figure, $100 billion lost annually in the US due to it. Right? Also, other than this very common ailment and something which can have very devastating consequences, there are many myths prevalent in the society, right? And very often these patients come to us and we need to spend time to try to explore these myths. So that is the importance of what we will try to be discussing today. Please feel free to make it an interactive session. Wherever you feel I am going overboard, stop me. Right? I know this is the day immediately after the Sahara, the festive season. So whenever you want to ask questions, feel free to, or at the end of it, fine. So whichever way. So you are all aware about the bony anatomy. It forms a protected passageway for the spinal cord. We also know that the spine, if you look at it from the front, is straight, but if you look at it from the side, it has lordosis and kyphosis within it. And this is very important to understand because the crux of the whole management of back pain will rely on this. Another important aspect that we need to understand is that when we stood up from 4 legs to 2, it was basically on the basis of strong muscles of the back. Because when we need to stand up from 4 legs to 2, the muscles have to be so strong that they can lift you up on 2 legs. But on 2 legs, the back comes at a biomechanical disadvantage. Whereas on 4 legs, the weight gets passed on through the 4 legs. Here, the weight has to pass through the back down. And that's why we need strong muscles to support our back. Now, again, I will talk about it here rather than later. Imagine the lifestyle 70 to 80 years ago, right? When men would work in the fields, work with the animals, would walk around. Females would, in addition to all this, go to the well, grind chakkis, do household work, look after animals. So, exercises were inbuilt within the daily lifestyle. But today our lifestyles have changed. It has become more or less sedentary and there are bad postures. And this is one of the most common cause why back pain has spread like a pandemic across the globe. When you look at causes of back pain, the most common cause is the mechanical cause. Right? There can be non-mechanical causes like inflammation, infection, tumor, metabolic, other causes. The most common cause in the vast majority remains mechanical, strain of the muscles, strain of the joints of the back. So, as we talked about the predisposing factors leading to weak muscles is the sedentary lifestyle, bad postures. You see how our children slouch in the bed to watch TV or read, or how they slouch in the sofa. And then when pandemic came in, work from home added another dimension because people were working from home in not ergonomic environment. Obesity also adds stress on the back, and you'll say what pregnancy has to do with back pain. During pregnancy, all the muscles, because of hormones, get weak, dilated, and also the center of gravity shifts forward. So after pregnancy, women need to tone up the muscles in addition to doing regular general conditioning exercise during pregnancy. But this seldom happens in our community in India, and that lays the seed for back pain in many women. What does stress or a stressful lifestyle have to do with back pain? Pain is a very complex phenomenon, right? So, you have any other stimulus in any other part of the body, the pain will flare up, will increase. So, similarly, if the mind is not at peace, then the threshold to bear the pain reduces. Also with pain, back pain comes in stress. With stress, your threshold to withstand pain reduces. That increases the pain, that increases the stress, and the vicious cycle comes in. So that's why all chronic pain, we say chronic pain when pain is more than 3 months since it started, there is definitely a psychosomatic component or the mind sensitization which comes in, and the psychologist forms an integral part of the team which manages chronic back pain. So, The good news is that most episodes of back pain will last only a short time. Only 75%, up to 75% will recover within 3 months. But as said before, many of them will have a recurrence within 1 year of the initial episode. Now, when we manage back pain, we need to determine the cause of back pain through a good history, good examination and a diagnostic evaluation. So very often these patients keep coming back to us. They have been managed at different places. Somebody prescribed an anti-inflammatory, another gave an injection. But unless we look at the cause of the back pain will keep recurring. So we need to determine the cause of back pain through a good history, good examination and a diagnostic evaluation. Also we need to rule out red flags and yellow flags. Red flags like fever, loss of appetite, significant trauma, bowel bladder involvement, that is mainly manifested by straining of urine or incontinence episodes, or then there is pain traveling down the leg, bonding stiffness, all these are red flags. And yellow flags signify psychosomatic components which may be there, which have a bearing in the ultimate threshold to withstand pain and management of pain. So, with regard to diagnostic evaluation, we need to be judicious in evaluating these patients by diagnostic procedures. Right? MRI should not be the first investigation that needs to be done, even though it's a gold standard. Most of them can be managed without radiographic imaging, especially if there are no red flags. But if there are red flags, we need to go in for an investigation immediately. And you know, there are various things that can be done. An MRI is a gold standard because you can see various sections and you can evaluate the soft tissues and the disc very well in the MRI. But then DEXA scan, if you think that there may be osteopenia or osteoporosis, PET scan if you are suspicious about a malignancy, a CT scan for bony anomalies, etc. may come in handy. How do you treat it? You treat the pain, you treat the cause, and you try to reduce the recurrence rate, right? The good news, vast majority will respond to a good conservative treatment. In fact, 97 to 98% will respond to a good conservative treatment. Now, many often the patients come to us have been advised. Just 4 days ago, I had a back pain patient who was advised to be who had been on the bed for 5 months continuously. Now, in our practice, based on evidence, we hardly advise anybody bed rest. Only if there is very severe pain, the person can't move around, we are aggressive with pain management. For 1 to 2 days, we would have them on the bed. Now, idea is if they are on the bed, the muscles get still weaker and there are more chances of the pain becoming chronic. So the idea should be to let them move around as much as they can comfortably so that the muscles don't get weaker further. In the treatment, we have proven treatments and we have unproven treatments. Proven are those which change the natural history of the disease. Amongst the unproven treatments, heat, ice packs. That doesn't mean unproven treatments do not have a role in management, but they will not change the natural history of the disease. Deep heat in the form of like diathermy, ultrasonic, laser therapy, TENS for leg pain. We generally don't use traction, but if leg pain is refractory, some people prefer to go in for traction. Corsets, generally some people the pain will increase with corsets. If they tend to benefit with corsets, fine. They could use it temporarily till they build up their own muscles. Pharmacotherapy through non-steroidal anti-inflammatory drugs, muscle relaxants were required, opiates, but neurotropic drugs like pregabalin, gabapentin we use mainly for radicular pain. And if the person doesn't respond to a good conservative treatment, we would give a trial of 3 transforaminal epidural steroid injections at weekly intervals. And 60% of those who don't respond to a good conservative treatment for prolapsed intervertebral disc specifically will respond well to an epidural steroid injections, these 3 epidural steroid injections. Amongst the proven treatment, one of the most important one is patient education. So, because they need to understand that they need to rule out the predisposing factors and how something which is as common they should be able to manage subsequently, and how they bring about the lifestyle changes. The patient education is a very important component of back pain management. The second most important proven treatment is aerobic physical conditioning exercises. Right? Walks, treadmill, sports, aerobics, swimming, dance, jog, run. These are all aerobic physical conditioning exercises, and they have a clear-cut evidence-based approach towards management of back pain in strengthening the endurance muscles of the back. The other exercises like stretching exercises, they do not have as evidence-based role in management as aerobic conditioning exercises, but if people can add this to aerobic conditioning exercise, we encourage them, but they should do only those movements which do not increase the pain. Right, and then there are weight training exercises. They could be done if the patient wants, but they do not have a clear-cut role in management of back pain. So, in chronic back pain especially, it's not only the doctor, but the psychologist, the therapist, and the multidisciplinary approach comes in, and cognitive treatment and behavioral techniques often have a definite role in management. Yes, surgery is also one of the proven treatments, but as mentioned before, only 1 to 3% of patients with back pain would need a surgery, and especially if they have red flags. So, mechanical back pain, surgery has no role, right? It's only specific indications when these patients will need a surgery, and if a surgery is required, then it has very good effects in management of back pain. But these are statistics from the study. From 406 cases of prolapsed intervertebral disc that my fellow followed, only 5.4% of them required surgery ultimately. So what we are talking is not only based on evidence, it's also based on our experience in this regard. So when required, surgical management will have gratifying results, right? People say, oh, surgery can have complications, but when a surgery is required, not going in for a surgery can have more potential complications than going in for a surgery per se. And with advancements in technology, we will talk about that subsequently. Spine surgery has become quite safe. Right? So again, patients can be managed by a clinician. They should know when to refer them to a surgeon. In the case of any red flags, right, especially the only absolute indication for surgery we say is a cauda equina syndrome, right? Doctor साहब मेरे को strain करना पड़ता है urine pass करने के लिए 10 दिनों से. That's an immediate red flag for us. मेरे accidents हो रहे हैं, urine leak कर जाता है, right? We have to rule out other confounding factors in an adult, prostrate and other issues, in females, stress incontinence, etc. But the most simple test that we do, a fellow will do in the team, is a perianal sensation and a voluntary anal contraction. If the perianal sensation is reduced, then there are good chances that it is neurogenic in origin, the bladder involvement. You need to evaluate for a spinal cause. If the voluntary anal contraction is weak, then you need to evaluate. And how do we evaluate? A uroflowmetry and if required a urodynamics test. So that's why we work in tandem very often with the urologist. The same day we would get a uroflowmetry or a urodynamics done because If the bladder is involved, it's a surgical emergency. You need to operate within 48 hours. So this you need to bring out in the history and see, because very often the patients will not come out with it. We need to get it out from them if they have any surgical emergencies. Now, the rest of my talk, I'll quickly give you an overview of what we do as surgeons, right? For prolapsed intervertebral disc, for example, we used to manage it like the classical discectomy, then came the microdiscectomy, where we do microscopic discectomies, and now there are minimally invasive techniques, right? Like the endoscopic discectomy or the extendable retractor or the X-tube that we can do. The principle is same. If you erase the muscles to reach the spine, then it takes longer for the muscles to build back. Post-op rehabilitation is more painful. So preservation of the muscles is the most important thing, whichever way. Either in conservative management as Sir will vouch, or with surgical management. So rather than erasing the muscles, if we can reach there just by putting a guide wire, dilating the muscles by serial dilators, putting in a tubular retractor, attaching a camera to that and working through that portal, then we have a very good post-operative phase where the patients do not have as much pain and it's not as invasive, so the chances of infection also reduce. So as you can see here, just put in a guide wire, put in a series of dilators, attach a tubular retractor, and through a camera you can not only have better illumination, you can have magnified view, and you can do the same. And what you are doing with it is the same. How you approach there is only different, right? So like you can see here, this is a huge disc on the left side, and we localize it, put guide wire, put series of dilators, and then we put a tubular retractor, and we get out this big chunk of disc just through this small port. When I was in US in 1994, that's the incident, right? And we have only dilated the muscles. So when I was in US in 1994, there was this ad, right? 3 girls lying on the beach, one with a band-aid. Can you guess which of these girls had a major spine surgery yesterday? So the one with the band-aid, right? Because it becomes a daycare surgery. The world is moving towards daycare surgeries, right? So there are other minimally invasive techniques that you can follow. You can not only do a discectomy, you can also do a fusion. You can put in pedicle screws, minimally invasive, right? This is a video which will take you through it. Will not go through the whole, but you can put percutaneous screws now, and in fact, till quite some time, and you just dilate the muscles, and under image intensifier, you can put in the screws in the pedicles, and you can attach a rod through a minimal incision again. So we'll not go into the details of it. Then you can do that through an expandable retractor also, like a quadrant. Now, there were the alternatives of fusion which came in. Like in your car, if there are 4 shockers, if one of them is not working properly, then more stress comes on the remaining shockers. So similarly, if you fuse one disc, so more stress, because disc works like a shock absorber. So more stress comes on the adjoining discs, and studies show that they degenerate faster and the chances of surgery for those discs increase. So rather than going in for fusion, world is moving towards non-fusion technologies where possible, or dynamic stabilization, right? And one of these is lumbar disc replacement. Then there are dynamic interspinal stabilization. Like you can see here, you can do that again percutaneously, right? If the back pain is equal to the leg pain or more than leg pain, from the side you can put in an interspinous stabilizer, right? Just through this again dilators, and then push in the interspinous, this small interspinous tool which will increase the interspinous space and stabilize it. We call it a dynamic stabilization, right? So you can do it over 15 minutes after an endoscopic discectomy that you have done, right? Then you have dynamic pedicle screw-based systems also, like the Dynasis. In the cervical spine, the disc replacement has more of a role than in the lumbar spine. Rather than a fusion, you can put in an artificial disc, right? And we started with cervical disc replacements way back. This surgery done in 2003. A young female, 45 years, you can see 3 big disc prolapses causing myelopathy for the patient. So cord was involved. And if we fuse all these 3 discs after 15 years, what would happen to the spine? So through a stereotactic technique at that time, we used to put in disc replacements, and you can see this. She still comes for a follow, and there is still preserved movement at the disc for this female per se. Now coming to the topic which Sir also would be dealing with in a large way, spinal injury, something very close to our hearts, because these people do not get the right management most of the times in our countries. You see, till the Second World War, spinal cord injury, Dr. Wadhwa will also vouch for it, was described as an ailment not to be treated. Right? People used to, in the First World War, for example, during the World War, you have a lot of spinal injuries, right? A lot of trauma. So 90% of persons who got spinal injury died within 1 year. Only 1% survived 20 years. It was only during the Second World War that 2 stalwarts revolutionized spinal cord injury management. And it was mainly through a comprehensive rehabilitation, including bladder management. People would die because the bladder was not managed properly, and renal failure would take place. Would die because of pressure source infections, chest infections, etc. So just with the proper rehabilitation, comprehensive rehabilitation, they were able to demonstrate that these people can get back to a near normal lifestyle. And the first spinal injury center came up in Stoke Mandeville Hospital in UK. And that's where our mentor, Dr. Mangala, knows him so well, Major HPS Ahluwalia, the Indian mountaineer and the one who did India proud by being the first team to scale Mount Everest way back in 1965. Exactly 6 months later, in the Indo-Pak war, he had a war injury. For 2 years, he was shunted from one hospital to the other because nobody knew how to manage spinal injuries. So in developing countries, emerging countries, spinal injury management generally takes a backseat because other ailments where you can show better results with less expenses are given more priority by the government. It was only after 2 years when Mr. H.C. Sarin, the then president of Indian Mountaineering Federation, who later became a defense secretary and was very close to Madam Indira Gandhi, he helped him go to Stoke Mandeville Hospital in the UK, and there the director, Dr. Walsh, encouraged him to build up similar services in India. And that was how the seed for Indian Spinal Injury Center was sown. Though he came back, they started thinking about it in 1983, a society was registered. Work started in 1991. Madam Indira Gandhi was the patron because of Mr. Sarin, and then Mr. Rajiv Gandhi became the patron for the center. And thanks to these gentlemen, this center, which is a wonderful gift to the society, came up, and where we can have as good a management as anywhere in the world. But we require a multidisciplinary team approach. It is the most expensive of all medical managements. You need to manage associated trauma, intensive management needs to take place, prevention of complications needs to be taken care of, manage the vertebral fracture, like in this case with a traction, and you need a surgical management in few cases. You could do that through an anterior approach or through a posterior approach, depending on, and you can again do it minimally invasive, like in this case there was a minimally invasive spine fixation across 4 levels for this patient. Again the same principle, just dilate the muscles, put in the screws, put in percutaneously the rod. You can do that. You can go in thoracoscopically and do an anterior decompression in these cases after you have fixed posteriorly. This is also very often used for pot spine or tubercular spine, where you under good vision of a thoracoscope, we are tying the segmental vessels here, and then do a discectomy, do a corpectomy, and do a decompression, put in a bone graft after you have fixed it from behind per se. So, and if you go in thoracoscopically, you are not opening the chest, so people with chest compromise also, you can do it well. Now, there are advanced techniques for management like pain and spasticity management. You can put in a baclofen pump for spasticity. For pain, you can use spinal cord stimulator. Nowadays, the spinal cord stimulator is used for another reason, though it's still under research and experimental. But you know that if the spinal cord cells die, they do not regenerate. That's why if there is a complete spinal cord injury, the person will have complete paralysis below that level for the rest of the life with the technology available as of date. So though stem cell has had a lot of hype, but it's still totally experimental. There is no evidence that we have done 2 clinical trials and we have published it, but it still continues to be misused by people, charging people for an experimental therapy. But where you can show good results is you put in an epidural stimulator. It's a 16 electrode array, just like the spinal cord stimulator for brain, and connect it to an electrical stimulator which you implant in the abdomen, in the subcutaneous region. And externally you can then map it, and you can get these people to walk with a walker. So this is a research trial that we are doing with good results. But ultimately, rehabilitation forms one of the mainstay. The person may do without a surgery, but can't do without a comprehensive rehabilitation and without prevention of complications. And unfortunately, many of the times these patients are operated upon and sent back home. And then they come back to us or sir after 1 year with complications, with contractures, with a failing kidney, with all those complications, they would come back to us. But not only physical rehabilitation, psychosocial rehabilitation, sexual rehabilitation, vocational rehabilitation, rehabilitation into the community. These people need to be empowered to be able to get back to a normal lifestyle. They should not be pitied upon because they can get back to a normal lifestyle. And of course the dictum, prevention is better than cure, holds the most relevance with spinal cord injury. In a country where people still put on the seatbelt only to prevent a traffic challan, right? So we have to prevent these injuries, because once there is a complete spinal cord injury, we can only rehabilitate, we do not have a cure. So osteoporosis is another topic, right? We have a lot of people with osteoporotic vertebral compression fractures. Again, these can be prevented, screening needs to be done. 99% of them respond to a conservative treatment. In fact, 60 to 70% of them you will only note in an X-ray which is done subsequently. But on the other hand, right, we lose the opportunity for treating osteoporosis also in most of the patients, right? It is official, evidence-based, mentioned in literature that more than 80% of the patients who have hip fractures or osteoporotic fractures
are not managed for the cause, that is osteoporosis. And then they will come back with another osteoporotic fracture. So we need to tap the opportunity to treat the osteoporosis. In fact, before that we need to prevent osteoporosis, right? Those at risk factors need to be screened for osteoporosis, need to be managed so that osteoporosis does not set in. And if the osteoporosis does come in, it should be managed appropriately. And management does not only involve pharmacological management. As important is calcium supplementation, protein-rich diet, fall prevention and general conditioning exercises, and this should not be missed. And of course, if they do not respond to a conservative management, you can do a vertebroplasty or a kyphoplasty procedure, which is a very simple procedure, again percutaneous. As you can see, why kyphoplasty? Because if you inject cement, it can leak locally or distally. Even it can cause pulmonary embolism. There can be death because of this. So if you create a space by a balloon and then put in the cement there, these chances of leakage get minimized. And a very small percent of them will need a fixation where there is an instability per se. Myelopathy, again, compression of the spinal cord, you may need to go in anteriorly or posteriorly, can be managed very well. Pot spine with kyphotic deformities, again, we need to, the management of pot spine has moved from mortality till the 40s when chemotherapy was not effective, to reduction of morbidity, and today reduction of kyphotic deformity. Because if you don't manage them properly, they will go into a kyphosis. This young girl of whom we, I think 2004, we managed with very cheap implants. We had to do 3-level vertebrectomies all from behind. And you can see the spinal cord here, we are working in front of the spinal cord from behind only, and you can see we put in a big sized cage replacing 3 vertebrae just from behind, and we corrected the deformity in this young girl, and she did well subsequently, very well. So you need to follow the simple principles of surgery to keep it stabilized, and you will see here this big cage that we are putting in just from behind and tapping it into place and then compressing and correcting the deformity. So deformities like spondylolisthesis kyphotic deformities need to be corrected. Again, this 3-year young girl, again operated upon, and just from posteriorly the kyphotic deformity was corrected. Neuromonitoring ensures that we are monitoring the spinal cord during the procedure, and if there is any deficit, we can make amends there and then. So, in most of the, I just came today, I finished my 130-degree scoliotic deformity with a 60-degree pelvic obliquity surgery, 630, and then I had to rush here. And this is again a young girl from a lower socio-economic strata, who was trained with Amar Jyoti Sansthan, and on Madam Uma Kuli's request, we had taken her out and had done the surgery. Ankylosing spondylitis with kyphotic deformities, you can do an osteotomy and correct it. This young girl had a respiratory failure because of her spinal deformity, because of the lordosis, and she had been sent back home at another center saying that we can't do anything for you, you spend the remaining part of your life, 1 year or whatever, at home on a BiPAP. So we put her on halo gravity traction. She had segmental anomalies there was a bar in the spinal cord across 6 levels. You could see the bony segment. So we put in a halo pelvic traction, halo gravity traction, then a halo pelvic traction, sent her home, corrected the deformity, and then fused her in situ with good results. She has normal respiration now. She is doing well. Now, one of the main things that people are worried about spine surgery is, Dr. Sahab, वहाँ तो spinal cord, and अगर थोड़ी सी भी गलती होगी तो क्या आप paralyzed हो जाएंगे लाइफ में, right? So That's why one of the main things that we've been working on is accuracy, right? To prevent that neurological deficit. The other thing is, when we go in minimally invasive, we rely on CM, so there is a lot of radiation. So, to reduce this human error and the radiation, first came in navigation from the tradition. Navigation technology, you can reduce the radiation, you can make it more accurate, right? So, but then it has inherent problems also with it. So, now what has come is the robotic technology. Though I must say that we still have not evolved with robotic technology, tapped the potential to its full, but it is there, this technology is there, and we can use it very well. You can plan your surgery one day before on the CT scan over a cup of coffee, and then you need to go in. The robo, after you have registered the case, will move, the effector arm will move as per the plan, and you can put in the pedicle screws safely with a high level of accuracy, right? So you affix the robo to the human being through an iliac pin, and the robo will define a safe area for its work, and then you register it, and then you move the effector arm, say go to L4 pedicle screw right, it will go there, and you just need to drill through it and put in the screw. And on top of it you can add the navigation technology to the robotic technology, so that you can see where your screw is going and correct it where you can. So it has a number of advantages when you compare it with freehand or navigation. I will not go into the depth of it, but after all, when you do the execution freehand, you do not have as much control, even though once you are past the learning curve, you are fairly accurate. Navigation is partial freehand, but robo is totally through the robotic effector arm. And a good evidence of accuracy, lower complication rate, lower chances of resurgery, less radiation, 74% less radiation than the conventional technology, 50% less radiation than navigation, right? And people who have robotics tend to do more minimally invasive surgery than those who do not have, as is evidence from the publication. So, very well published, and just will give
robo has a navigation component and a robo component. So you can see that it combines both the robotic technology with the navigation technology. I have the self-navigation here, the robotic arm, as you can see here, right? The beauty of this robo is that you have it strongly interface with the patient so that they act as one unit. So we have used, so once you attach this, now they are one unit. The one image, that becomes evident here, and you can plan the surgery on the rope. It's a three-dimensional deformity. So once you have attached the robo to the patient, you need to define a safe area in which the robotic arm can move. And 3D defined, that is what the robo is doing right now. Working out a safe area for itself in which it can move of it. Right? And any patient safety is the first and foremost part. So if there is any doubt, you should then reconfirm. Right? And then after you have also done the tapping, you should again see with the sound. But as you come to know the robo and the robo starts understanding you, all this becomes very simple.
So that you can see the robotic arm has come there, and you can see under navigation where you are going into, right? But it is mainly guided with the robotic arm as per the plan you have made on the image. And OARM is like
OAM is right now, beauty of OAM is interfacing with the robo is that previously the registration used to be a bit tedious to make it sync with the CT scan which was done before. With the OAM, which is itself like a bone being the CT scan, right? So you take the images as the patient is positioned, so you are more accurate.
So the OAM is like a CT scan which will take place on the operation table, and then the images go right into the robo, and you can plan it there and execute it there. Or you can plan over a CT scan image the day before and go forward. So you can manage trauma, as you can see here, through robotic ways, or osteoporotic unstable fractures percutaneously, cement augmented, as you can see in this case, or pod spine. This was a revision surgery which was done because she got infected elsewhere, managed earlier elsewhere, at the cervicothoracic region. This was a cervicothoracic kyphotic deformity as a result of a healed pod spine, which we corrected also with robotic technology. Again, TLIF, multiple levels, degenerative spine, that's the bread and butter of spine surgeons. So here, the robotic surgeries make it very easy. Deformities again can be done robotic. In fact, on the 31st, we will have a live demo for few surgeons with also robotic deformity surgeons from US coming in here. We will have some live surgeries. This kyphoscoliosis that you can see here managed through robotic, and spondylolisthesis again managed through robotic arm. So it is evolving. Soon we will have automatic planning, MRI, we can plan on an MRI, we can mold the rod with the robo, and other technologies will come in. And friends, this is always teamwork. Dr. Mangla knows that at ISIC we were all part of a big team because the pulmonologist was as much a part of the team managing spinal injuries as was other people. So at Balaji Action Medical Institute, again it's a team. We have a good rehab unit and we have a good team of surgeons who are there, and we are providing services for all kinds of spine surgery, spinal problems there. But as mentioned, most of these problems can be managed by any clinician. They only need to know when is the time that we need to refer them across to a surgeon. So, spinal ailments are amongst the most common ailments and can have devastating physical, psychosocial and economic consequences. Evidence base has exploded many prevailing myths pertaining to their management. Most of the spinal ailments can be managed by the general physician. The dictum prevention is better than cure is especially relevant for spinal ailments. Most patients respond to conservative treatment, which should be the first line of treatment with a few exceptions. This comes within the purview of any general physician, or you can say a rehab person also. Various cutting-edge surgical technologies have revolutionized the management and outcome of spinal ailments. The myth that spine surgery is not safe has been exploded. Any professional involved with management of spinal ailments should be well versed with the basic principle of conservative management. Robo today is revolutionizing surgery, optimizing recovery, and eventually helping surgeons to focus on the core work. So we have evolved from conventional technology to navigation to robotic technology now. Thank you for your patience.
Had on this forum, and from a region, none other than Dr. H.S. Chhabra himself. I am sure there must be many questions. It's 10 o'clock and we can take this discussion to 10:25. And I would, yes, Dr. Podar sir, I would request all of you to keep your questions to the point and relevant to everybody in day-to-day practice.
First, Dr. Chhabra, my compliments to you because you covered non-surgical management very well and you gave ample time to that also. Like in Tata Steel ad we used to see that in the last day you used to say we also make steel. So in the last you said we also do spine surgery. My question is, in robotic surgery you said where will you enter the body will be decided by the robot in case.
No. It is decided by, it is planned by us on an OAG image or a CT scan image. But we can plan it on an image, both coronal, sagittal, in all three planes, so that it is accurate. And then the robo helps in implementing it. Once we have planned that, so executing it such that it reaches exactly the same place where by entering it you will go through that plan, right? That is what the robo helps in doing.
Right, because in robotic abdominal surgery, robot has no role in where to enter from. So that you made it clear. Thanks.
Sir, spine robo is slightly different, right? Robo, as you all know, was invented because so that you can do remote surgery, right? Like in Vietnam War, there were a lot of people getting injured, and they did not have access to the good surgeons there, and it was not possible to fly them back to the US. So they invented the robo such that the surgeon sitting in US could, through remote sensing, operate in Vietnam with the help of someone there. But in spine, it doesn't have that function as of today. It only helps in improving accuracy. But the scope is increasing. It will help in a number of other things subsequently.
Thank you.
Dr. Mangla sir.
Look, as we know, like lung TB, pot spine is also very common. And whenever we diagnose a lung, we always try to prove whether it is drug-resistant TB or we are able to put up cultures. So as and when you are able to prove that this is a drug-resistant pot spine, for treatment, do you send these patients to neurology center because the drug-resistant treatment is different, like bedaquiline, lanezolate, moxifloxacin, and cycloserine. So what do you do, and how often you try to prove that this is drug-resistant TB? Like clinically, you know this is pot spine. Whether you give the entity straight away or try to get the tissue in most of the cases and try to put up cultures.
Sir, you have a very relevant question. In India, the drug resistance is coming up, but MDR still has not reached that level. WHO has clearly defined in TB spine, where you definitely need to go in for a biopsy in all cases, where the incidence of drug resistance overall is more than 6%. Right? But in our practice, we have not found it to be as high. So we always, wherever there is a typical tubercular lesion, right, young patient, paradiscal involvement, we will say, okay, we can go in for a biopsy to confirm, but it seems like a typical lesion, so if you have any issues, we can also go in for a therapeutic trial. If you do not improve within 6 weeks, then we can go in for a biopsy. So that is the option that we generally give. But if it is an elderly, right, where there are chances also of other mimics, TB mimics like malignancy to be there, we always suggest that we go in for a biopsy. Whenever an MDR is diagnosed, right, we refer them to our pulmonology colleagues or an infectious disease specialist who are more well versed. But if it is a simple, plain anti-tubercular treatment, we do that on the
Dr. Bhalla sir.
Chhabra, in your practice of microdiscectomy, how often you get spondylolisthesis after that?
How often do you get?
Spondylolisthesis.
Sir, if you get listhesis after discectomy, that means we have violated the facet, right? Or there was back pain, substantial back pain, along with leg pain, and we have not done a dynamic X-ray to rule out instability in that patient, right? So either you have created the instability, or the instability was there before and you have not diagnosed it appropriately. In a properly done discectomy, right, where there is no instability, listhesis should not come. But we are all human beings, right? We are all prone to errors. The advantage of doing minimally invasive is that you are right at the spot you have fixed, right? My guide wire is on the disc. So there are less chances of the facet violation taking place than in an open disc entity. Right, sir? So we see that very less often, but of course, most of these discs are managed by common orthopedic surgeons who also do spine surgery. So we sometimes see this as a result of our clinics.
So if the focus is on 2 or 3 discs, do you fix it?
No, sir. The higher we go, the neural element canal ratio increases, right? So there are, we do not want to retract as much, and the disc becomes more separate. So if it is a L1-2 disc also, we will still say that we will go in, we will try to preserve, but in case we feel it is difficult and we need to do a facetectomy, we will instrument it there. So we take that permission from them and always inform the attendant when we need to go in. 98% of them we don't need to instrument.
Dr. Manish has a question.
Sir, as a group of family physicians, I know asking a surgeon, but I think you could kind of guide us briefly, very short, because we were more on the surgical aspect, medical management of these cases,
Of a prolapsed intervertebral disc?
Yes.
Right. Leg pain equal to or more than back pain, right? Always rule out a sacroiliac joint strain, right? Flexion, abduction, external rotation at the hip, if it causes pain and if there's tenderness at the sacroiliac joint. Sacroiliac joint pain can mimic leg pain, prolapsed intervertebral disc, so that needs to be ruled out also. And if it is there, just injection, local injection there will relieve the patient both of the back pain and the leg pain.
Would simple X-rays work or should we do MRI?
No, we don't. I even don't need to go in for an X-ray. The diagnosis is made on the basis of symptoms and evaluation, not on the basis. You just need to go in for radiological imaging for validation before you go in for a surgery or a root block. So, what my protocol, conservative protocol, which I presented also in the International Society for Study of Lumbar Spine, and we are in the process of publishing, where we have a very good success rate, is we would start, of course, hot fomentation or ice packs, local counter irritant gel, TENS therapy for leg pain, shortwave and IFT for back pain, anti-inflammatories for back pain, and we use neurotropics. Our protocol is we start with 75 mg of pregabalin, ask them to increase by 75 mg each day or as they tolerate it, telling them that they may have drowsiness, giddiness. If that is excessive, reduce the dose and then add oxcarbazepine along with it. Total of maximum 600 mg. Otherwise, you can use gabapentin, where starting from 300 mg, we go up to 1800 mg. If you do not respond to 600 mg of pregabalin or 1800 mg of gabapentin, add duloxetine. 20 mg, increase it to 120 mg. If you don't improve, add amitriptyline. 25 mg, go up to 75 mg. If you don't improve, now is the time for a root block or straight for a surgery.
Role of steroids?
Steroids, I use it very often. Even people with severe pain, right? So I give them the option of going in for either transforaminal epidural steroid along with the conservative management, or in non-diabetics, intravenous or oral steroids. Intravenous 1 gram solomedrol each day for 3 days. Oral start from 16 milligram. Every 2 days taper it, 12 milligram, 8 milligram, 4 milligram and stop it.
Thank you so much.
Dr. Chhabra, you mentioned about giving the cement, and you mentioned that there is a risk of pulmonary embolism and other issues. Is the risk of embolism directly associated with the number of vertebrae that you inject with the cement?
Yeah. Total amount of cement that you inject, but the main thing is that when initially we used to do vertebroplasty. In a vertebroplasty, you put in a needle and inject cement. So you have to force cement in a much more liquid stage. So when you create the space through a balloon, then you put in cement at a much more viscous stage when it is at a toothpaste consistency. So you don't pressurize and you put it in a much more viscous state. So the chances of embolization, local leakage or distal leakage reduces drastically. And we have seen people who have become paraplegic because of local leakage, and we have seen people who have died because of pulmonary embolism, because of cement embolism. So kyphoplasty is a bit more expensive, but now with all these available, it's not very expensive as compared to vertebroplasty. You can get a kit for 35,000-40,000 also, a kyphoplasty.
At times, when you are addressing the issue of osteoporosis, especially in postmenopausal female, it's not 1, 2 or 3 days, but multiple vertebrae, which are osteoporotic. So how many do you give cement to, and how do you decide that which one is to be cemented?
So most of them will respond to a conservative treatment, right? Very often facet blocks because of the anterior wedge compression. Facets come under stress, you give facet injection and they respond to it. But if they have not responded, then wherever there is maximum tenderness, you can put in, and nowadays we do vertebroplasty or kyphoplasty under local anesthesia. So we'll ask them if they have relief of pain. We will even get them to walk and see if they have relief of pain. If not, inject another level. So gone are the days when we used to do kyphoplasties under general anesthesia or vertebroplasty. We do because most of them are osteoporotic and the needle goes in easily. You can do it under local anesthesia, and also if the patient is having any complications like local leakage or no satisfactory relief of pain, you can assess there and then.
Sir, my humble question as a physician, does it actually change the natural history of the osteoporotic vertebra?
The
Cementing?
sir, again 1% to 2% of osteoporotic vertebral compression fractures ever require cementing, right? So it does not change the natural history. If the pain has not responded, it will help in getting better relief of the pain. So that's it. You still need to treat the osteoporosis to prevent adjoining. And again, a word here. It is not only morbidity which is caused by osteoporotic vertebral compression fractures, it adds to mortality. Studies show 8 times higher risk of mortality in people with much more than even the hip fracture. If we do not treat the initial vertebral compression fracture appropriately with a comprehensive management, people go into a vicious spiral. Because of the kyphosis, adjoining segments come under stress, they will also start collapsing. Gradually, the chest reserve will go down because the multiple compression fractures have become. The gastrointestinal issues, respiratory issues, quality of life gets affected. It ultimately, the spiral leads to an enhanced mortality also, respiratory insufficiency also. So we need to treat at the first opportunity.
Sir, something which is very dear to me as a physician, and I give graphic cases of osteoporosis to my friend Dr. Baba, and he says alendronate is not the final answer for osteoporosis. That at times it can actually be counterproductive. Your view on that?
So we have had a very large experience of managing with alendronate, but then gradually better products became available. So the main problem with alendronate is taking it weekly, right? Morning, empty stomach, then not to eat anything and not to lie down for half to 1 hour after taking it. The compliance becomes low. So if you can give a once-a-year therapy in the form of zoledronate acid, so again a type of bisphosphonate, the compliance improves. But then there are other better opportunities now, like denosumab, right? And if there is severe osteoporosis, WHO defines severe osteoporosis as a T-score less than -2.5 with a fragility fracture. So there, teriparatide has a definite role, but gradually, here also denosumab is gradually, because of the need to give it once in 6 months, rather than everyday need for teriparatide, it is gradually replacing also teriparatide in most of the cases.
Sir, my last question. There is something called osteoporosis and osteoporosis with very severe pain. Now with osteoporosis with very severe pain, there is a calcitonin nasal spray. What is the role of that? I just a few words on that.
Calcitonin nasal spray, sir, does not help with the management of osteoporosis. It only helps with the pain due to the microfractures which are there. So if given for a long time, it can cause nasal issues also. So 1 month, 2 months in that phase. But see, in a country, we are in a country like India where vitamin D deficiency is also rampant. And very often the acute pain which is there, which you think is because of osteoporosis, is due to osteomalacia. So if you get the vitamin D levels done here, they are low. I got a lady from UK who was on the bed for 6 months there, managed for osteoporosis. We did an X-ray pelvis with both hips, there were loser zones. We treated her with vitamin D. In 6 weeks, she walked back. Right? So, very often osteomalacia and osteoporosis are coexistent. And when we talk about these terms, we also need to be well versed with sarcopenia. Sarcopenia is weak muscles which are very often there along with osteoporosis. And if we do not treat the sarcopenia, we do not have good effects with the osteoporosis as well. So we need to be well versed with its management.
If on DEXA scan scoring -2.5 and there is no history of fracture, will you still use injectables or you can use alendronate?
We can use alendronate, sir. In fact, many of the guidelines mention using alendronate. But because of compliance, right, sir? Now, denosumab, once in 6 months, the cost can be 5,000, 6,000 rupees. So 10,000 a year expense. If you use alendronate also is as expensive. The efficacy is much more. And it has shown to be, you can use it long term. So you can start with denosumab and because at some point you will need to go for a subsequent maintenance. Then you can add bisphosphonate there or zoledronic acid.
Have you ever encountered mandibular necrosis?
So that is more with the bisphosphonates and zoledronic acid. Not very less with denosumab. Very less with denosumab. Denosumab is a very safe drug.
Dr. Narendra Singh has a question, sir.
Right.
Sir, in your one of your first I'm a general physician. आपकी पहली 2 स्लाइड में एक वर्ड यूज किया आपने chiropractor.
Right, sir.
As a family physician, जितनी भी elite class के दिल्ली के लोग हैं, जब भी बैक एक होती है, वो chiropractor के पास जाते हैं, वो 2,500 रुपए एक विजिट के वो chiropractor ले लेता है. और आप कह रहे don't visit the chiropractor, sir. तो ये ground reality है, sir. तो क्या है? What is chiropractic and why this elite class is running towards that? For that.
Sir, वो myths में बोला है. Myths में. But myths now, a chiropractor in US has a much bigger practice than a orthopedic surgeon, right? But इंडिया में कितने ट्रेन कायरोप्रैक्टिस हैं सर आप बताइए मतलब इंडिया में कोई कायरोप्रैक्टिस का ट्रेनिंग कोर्स ही नहीं है ठीक है जो these are self styled chiropractors ठीक है और वो कई बार फिर जबरदस्ती मैनिपुलेशन कर देते हैं they come to us with complications
सर ये थोड़ा सा ब्रीफ में बताइए होता क्या है जी कायरोप्रैक्टिस में क्या करते हैं
it's a different totally different branch where they manipulate the joints and the muscles India में sir in US it's a training course India में बहुत कम है जो बाहर से ट्रेनिंग लेकर
सर पर यहाँ जो ग्राउंड रियलिटी है एलिट क्लास के लोग वही मांगते हैं सर हम लोग बोले कि बैक एक है ये लोग वो कहते हैं कि नहीं वो 2,500 रुपए सर एक विजिट के सर वो लेते हैं कायरोप्रैक्टिस
सर थोड़ा सा आजकल फिजियोथेरेपी में भी एक टेक्निक है मैनिपुलेशन ठीक है ड्राई नीडलिंग उसको भी लोग कंफ्यूज करते हैं कायरोप्रैक्टिस से और वो भी फिजियोथेरेपिस्ट भी सेल्फ स्टाइल कायरोप्रैक्टिस होता है
It's your job to convince the patient where to go.
Sir, Dr. Chhabra sir, we had a wonderful presentation by you and wonderful question answer session. Sir, but your MCH bar still stands, sir. We have two wonderful academic pillars of the professors, Dr. JBS Tulsi and Dr. ML Kalra sir. Over to them for next 10 minutes.
I will ask only 3 minutes and 7 for it. Chiropractor, I have a very good experience. They have more of a psychological treatment also. So they are not only one of the pathies I came to know is postural correction therapy. One of our very good renowned orthopedician is into it. I don't want to name him, in GK1. He is a good practice. And recently I came to know that they are coming with some artificial intelligence boosted shirts having magnets to record your data about your posture when you are stooping, when you are sitting straight and all that. So they are also coming for the correction of the posture. Posture correction is a big thing. And chiropractor, of course, I agree, they have a lot of psychotherapy. Sir, my question related to my mythological knowledge about the Dhichi. If you know the Dhichi, the Dhichi was the saint who donated his spine to the Lord Indra to fight with some demons. So is it possible to donate your spine and keep you living because you have artificial disc and all that? I think we are in the beginning of that era.
So, we can have vertebral transplant, but unfortunately, we cannot have a spinal cord transplant. Right? So, there is a lot of research which is going on, but they have been limited to success only in the preclinical trials. So once that is successful, then spine transplant would take place. Baki मैं बोलता हूँ sir, posture I could because of the limitation of time, but correction of posture is one of the very important the patient education programs that we have, because bad posture is one of the rampant causes for the back pain spreading like a pandemic. But sir, वो नाक पकड़ना ऐसे पकड़ना रोबो से भी पकड़ सकते हैं, बस उतना ही फर्क है. मतलब पुराने जमाने में तो लोग अच्छे पोस्चर में बैठते थे. So a good knowledge about what is a good posture I think is very important.
Since I had promised 7 minutes to him, my last minute is about fluorosis. Has there been any advancement? When we were students, fluorosis was difficult to treat. Anything better than my student life?
अभी खाली यही है कि we should be able to counsel the patient properly. अगर आपको X-ray forearm में दिख रहा है fluorosis, तो the outcome is not as good. Sir, I'm not aware, but I think the management is still where it was.
Thank you, sir.
Thank you, Dr. Chhabra. That was indeed a very enlightening talk on spinal injuries and risk management. So, for OVFs, that's the osteoporosis, vertical fractures, conservative treatment is the primary treatment option. Bed rest, analgesics, anti-osteoporotic medicines, brace. But numerous studies, have talked about vertebral augmentation, especially about vertebroplasty and kyphoplasty. So debate and controversy, continues. What do you have to say about OVF? Would you probably manage conservatively, or would you probably go for vertebral augmentation, sir?
Sir, the essence remains the same, because 99% of them will respond to a good conservative treatment. So give a good conservative trial. If the patient is not improving, with a good conservative trial, at least 6 weeks of therapy. In fact, in osteoporosis, we even go in for 3 months of treatment. If the pain is acute, then you can go in for a vertebral augmentation.
So 15 to 35% of the patients probably could not respond to conservative treatment. Especially, you see, if you have intractable pain, if you have, what do you say, collapsed vertebra, or you have a neuro probably deficit, such patients probably need to have a surgical intervention, especially vertebroplasty or kyphoplasty. What do you think, sir?
Sir, at the first go, if the patient comes to us and the collapse is substantial, in that it is likely to result in a kyphotic deformity more than 30 degrees, we say 20 degrees. So then we would go in for a vertebral augmentation straight away, suggest vertebral augmentation. Neurological deficit is seen with less than 1% of people with osteoporosis. But there are some prognostic factors which can suggest that this vertebral compression is likely to go into neurological deficit. There we need to monitor, and at the earliest sign here, it's not only augmentation, but we need to fix the spine as well. Fixing the spine in osteoporosis used to be a nightmare because there would be implant failures, etc. But nowadays we use cement augmented fixation. So we put in cement, put in the screw, and the results there are good. So there, with the neurological deficit, we need to remove the compression. So they do need augmentation or surgical management, but that is in a small subset.
So 50 to 30% of the patients probably need that. Finally, my last question would be about osteoporosis. Dr. Podar, where are you? He talked about this postulate no longer doesn't have any role today in osteoporosis. Probably teriparatide is a drug to be used today. So this causes spinal fusion, and this is a drug to go for osteoporosis. Your comments on teriparatide, sir?
Teriparatide, as I said, sir, we use mainly for severe osteoporosis, means any patient with...
It dramatically improves spinal fusion.
Right, sir. But unless...
And fracture healing as well.
Yeah, so fragility fracture, in a patient with fragility fracture, when T-score less than -2.5 is an ideal indication for teriparatide.
Thank you, sir.
When there is no fracture.
And not only that, lower mortality as well. Thank you, sir.
Right, those who have no fractures, the indications are glucocorticoid-induced osteoporosis. Because there it will not respond to denosumab or bisphosphonates. There the drug of choice is teriparatide.
If there is no glucocorticoid actually, then
we would not go in for teriparatide. So because teriparatide as of date, though now you can extend it beyond 2 years also. FDA approval is for 2 years. Beyond that, under monitoring.
you can always add teriparatide after this.
Yeah, definitely. If there is a fragility fracture, if they are not responding, and when you finish with teriparatide treatment, you still need to have maintenance therapy. You will still come to denosumab or bisphosphonates, because otherwise the bone density will fall again in the next 2 years.
Friends, all of you would agree that we had a wonderful CME on spinal issues, moderated by our erudite moderator, Dr. Asif Alba, whom I would now ask to summarize this CME for us.
Thank you, Sushil. We had a wonderful and very, very comprehensive overview of almost everything which can happen in the spine. So my